talk to you about new options for advanced breast cancer.
Thank you very much, Mitch, and thank you everybody for coming. So in terms of metastatic breast cancer, which is recurrent or secondary breast cancer, I'll give you a little bit of an update of what's been happening, a little bit of explanation of what that condition is and how things are really quite rapidly changing for the better in terms of outcomes. Clearly, despite the improvement in cure rates, unfortunately, metastatic or secondary breast cancer still does occur, and it is a significant shock to individual patients when that occurs, and it is a long-term burden for patients because it's ongoing treatment for sometimes many, many years, which is a good thing, but it is regular visits to the hospital, and I know that affects a number of you in the audience here. Also, as treatments have got better, and patients, as I'll show you, are now living longer, it has become a major impact for the NHS in terms of resources, not only for these new drugs, but also the size of patients and the size of the clinics, of many, as you know, on our Tuesday afternoon clinics. So the success actually breeds a big burden, not only for patients, but also for how we fund and support patients within the healthcare system that we have. The good news is that the survival of patients once they get metastatic disease is clearly improving. Now, if I'd given this talk 6 or 7 years ago, I couldn't point to any individual trial that showed you that a new treatment for secondary breast cancer could make you live longer. But that's all changed. And I'll show you examples in the different subgroups as how that's happening, including new data that just came out at the European meeting 2 days ago, and you'll be the first presentation of that data in the UK. But there are still gaps in our knowledge. Why does secondary breast cancer occur? Why do cells lie dormant in the bone marrow for years undetected and then come back as bone disease? So we've still got an awful lot to learn about what causes it to try and see if we can ultimately prevent it. But at the moment, we're really talking about how we can treat it. Now, about 5% of patients may present when they come with a cancer in the breast with it already spread elsewhere when we do our tests. But of those who haven't got it spread elsewhere, the old statistics said potentially up to 1/3 of patients could get cancer coming back at some stage. I think that figure is now getting less, but if you look at the old cancer research campaign statistics from 5 or 6 years ago, that's what it said the likelihood was. There are potentially up to 100,000 women, and that may be an underestimate, living with secondary breast cancer, but there isn't really a good registry to account for how many of those patients there are. It also depends on which subtype of breast cancer you have as to what the likelihood and when the cancer might come back. This is a small Finnish study that showed that basically if you have what's called triple negative breast cancer, which you're all aware of is a more fearful diagnosis, primarily because it's a diagnosis of default. It doesn't have targeted treatments yet. You can see that the risk is biggest within the first 2 or 3 years, and then it flattens out. And while hormone-positive breast cancer is thought to be a much better outcome, the reality is there's a small risk year on year on year, such that ultimately by the time you get out to 20 years, the risk of that cancer recurring is almost the same as triple negative breast cancer. So we still do have risks with each of the individual subtypes. They're just different. Now, people will say it's not a curable disease, but that is not meaning that it's not a treatable disease. It's a highly treatable disease, and patients have to live with good quality life, with treatment that they can tolerate now for many, many years, as we're starting to see. But we cannot turn around at the moment and say we can cure the disease once it is spread elsewhere. But that too may change as the new treatments become more effective. And the subtypes really depend on whether you've got hormone receptors, whether you've got HER2 that Alistair talked about in the original cancer, or whether it's got neither of those, the so-called triple negative. And I'll talk a little bit about each of those as to the highlights of the progress that's being made. Most cancers are the hormone-driven type. The triple negative is about 20%. We've got lots of different options, and when I sit and talk to a patient when we're first diagnosed, it's overwhelming. And you have to focus really on what the key priorities are. And we've got lots of different drug treatments we can use. We've got lots of different local treatments, whether it be radiation, whether it even be surgery in certain circumstances for solitary metastases, or some form of regional ablation therapy. So it is not just about drugs. There are local treatments that we can use, and we integrate all of these into the treatment. You'll see a new term there called immunotherapy. That's a lot in the Daily Mail, and then everybody asks about it, is it right for me? And I'll show you the data where it might be right for a certain type of breast cancer. But ultimately, what we do when we discuss treatments and discuss it with patients is weighing up the pros and the cons, the balances of benefit of treatment versus the harm and potential side effects. And we've got to get that balancing act right. Clearly, we want to improve the symptoms that the cancer might be causing, whether it's in the bone or the lung or whatever, with treatment that won't counteract that with other side effects related to the drugs. But if we don't give effective treatments, then the treatments may not work, and that risk of treatment failure is more symptoms and so on. So it's that balancing act of trying to find the most appropriate therapy. Now, people often say, how does the cancer spread? Well, traditionally, it's through either the bloodstream or the lymphatic system, which you'll see is this map throughout the whole body that will take cells and nutrients around to all of the tissues and all of the parts of the body. And ultimately, these are the sites where the cancer may end up, and different subtypes of breast cancer have a different propensity for different organs, and that relates to the biology. Ultimately, our ability to understand how a cancer can move from just in the ducts within the breast to invade into the tissues and spread around the body, that's the process of metastases that we still are trying to learn, because if we could prevent that at the outset, then we could eradicate and get rid of secondary breast cancer. But that's a much harder nut to crack. Now, since 2012, there have been 14 practice-changing trials, many of which have been done here at the Marsden, many of them led at the Marsden, and many patients, including those of you in the audience I do know, have been involved in some of these trials. So for HER2-positive breast cancer, Alistair kindly introduced those topics, so I won't dwell on those. A couple of slides I'll switch through, but the drugs that Alistair was using to shrink tumours before surgery or to give after surgery if there's still residual disease, we've had available since 2012 to treat secondary breast cancer. So either the dual antibodies or the TDM1. And you'll see the names of the landmark trials, Cleopatra and Amelia, that led to those being new treatments. For hormone-positive breast cancer, it is rapidly changing. In 2012, we had the first combination of a targeted treatment in addition to hormones, a drug called everolimus in a trial called Bolero-2. But the drugs called CDK inhibitors have really revolutionized the treatment, and the Marsden's been heavily involved in those studies, and there have been a total of 7 or 9 studies in total. But for triple-negative breast cancer, it's been a bit of a barren field, until recently, when immunotherapy is potentially changing things, as well as new drugs called PARP inhibitors. Now, Alistair showed you, I'll give you a couple of examples of each of those, just to give you some information about them. Alistair showed you how these targeted antibodies work, that the two together are better than either alone at blocking this complex set of proteins on the surface of the cancer cell. Alistair showed you that stain, that sort of checkerboard stain of browning, which is the HER2 positive. Under the, what it is this receptor here that binds with this other receptor, HER2 and HER3, and that sends the signals into the cancer cell to make them rapidly proliferate. And if you use a simple antibody that's essentially harnessing the immune system to mimic how we can block this, you can put a bridge in here and stop this signal from firing. And this is one of the best examples of targeted treatments. So this trial, Cleopatra, showed that if you gave the two treatments together, the two antibodies, rather than just the Herceptin with chemotherapy, patients not only had their cancer controlled for longer, they lived for longer. So this was one of the first survival positive studies, and on average, patients gained an extra 15 months of being alive with secondary disease, purely because of the addition of one drug. And that was enough to get it approved by NICE and widely available in the NHS. Alistair showed you this drug called TDM1, which is this piggyback, this Trojan horse of Herceptin taking chemotherapy into a cancer cell. And the trial in metastatic disease in the second-line setting, again, also showed that patients were living longer. Here you can see that at around about 2 years on the treatment, nearly an extra 15% of patients were alive if they got the TDM1 compared to a standard treatment we had before. Again, the NHS adopted this. NICE endorsed the fact that it was a treatment to be paid for through the NHS, and literally thousands of patients have benefited from these drugs over the last few years. Now, in hormone-positive breast cancer, we've had a good targeted treatment called endocrine therapy, which targets something called the estrogen receptor that we can measure in the cancer cells. But the recent research has found that there's a very tight cog or a network that makes the cancer cell divide called the cell cycle. And we've worked out all the different proteins and kinases that regulate that cell cycle. And to cut a long story short, and an awful lot of research, essentially if you use a drug to block the cell cycle at this particular target here, just as the cell goes through its division process, and you give that with a hormone treatment, the two together are much better than either on their own. And that led to the introduction of a number of drugs, palbociclib, ribociclib, abemaciclib, into the treatment of secondary breast cancer. But the recent news is that these drugs likewise not only just shrink cancers more and control them for longer, they also result in patients living longer. And again, we haven't seen that in hormone-positive breast cancer until these new trials came out. The studies come out in the New England Journal of Medicine, which is the premier international medical journal, if they are really practice-changing. And my colleague Nick Turner here from the Marsden Institute of Cancer Research led the very first trial just a year ago of the drug palbociclib and fulvestrant, showing that it improves survival. Another trial came out earlier in June. And then I told you that there was new data that came out on Sunday afternoon, so you're hearing this within 48 hours of it coming public, with two drugs called abemaciclib and ribociclib in the trials Monarch 2 and Mona Lisa. And we were again involved in the Marsden in the Monarch study. And these are the sorts of curves that you see in the publications. They're a little bit difficult to interpret, but they basically mean that by being on the combination of the drug compared to a hormone treatment alone, a proportion of patients are now living longer than if they were just receiving the fulvestrant. And that could be an average of anything up to 7 months in that trial, and in the studies that came out at the weekend, it's up to around about 9 months of extra life gained by being on these treatments. Now, NICE have already approved these treatments in the second-line setting, and this endorses the fact that they are practice-changing. So you can start to see that as these new drugs come in, given that they were only trialed for the very first time in patients literally 3 or 4 years ago, now to being widely available on the NHS is really groundbreaking implementation of the research for patients' benefit. And we'll continue to see if these drugs can then be used to prevent cancer coming back by using them after surgery. And those trials have been recruited and we haven't got results yet. But the final bit of breast cancer puzzle is really the group called triple-negative breast cancer, where we've struggled to find new drugs that really make that quantum of improvement. And the reason is that triple-negative breast cancer is very complex. It has a lot of mutations. This little diagram shows you all the different chromosomes in the tumor and how many mutations they are. In hormone-positive breast cancer here, there are literally 2 or 3 mutations. But in triple-negative breast cancer, there are hundreds. So it's a much more aggressive, faster growing type of cancer. But there's no one particular target that we can come in on, like in hormone receptor positive breast cancer. Triple-negative breast cancer is probably a mixture of 7 different diseases. These are the sorts of maps that the scientists do to try and work out the different groups of triple-negative breast cancer. They're these so-called heat maps that break them into different groups. And we now understand that there are some triple-negative breast cancers that behave a little bit like hormone-positive breast cancer and grow very slowly. And there are some that depend on a gene going wrong called the BRCA gene, and there are some that depend on the immune system. And understanding that allows us to now come up with better treatments. And immune therapy is really the new kid on the block in terms of this type of therapy. Here's a cancer cell that normally the T cell, the immune system, might recognize as foreign and try and get rid of it. But the cancers are smart and they turn on a system through this PD-L1 where they basically switch off the immune system and put the brake on it. But what the scientists have shown is if you develop an antibody here, you can turn the brake off and you can activate the immune system to start to get rid of the cancer. And the trial called Impassion was published last year that showed for the very first time this could actually make triple-negative breast cancers respond to treatment better, and again, that patients could live longer as a consequence of that. So this is, again, only for a subgroup of triple-negative breast cancer that express this protein, but we can now measure that routinely in the laboratory, and this is undergoing evaluation by NICE, and we hope that they will approve it as a new treatment very soon. So there is hope for metastatic triple-negative breast cancer, not just immunotherapy. There are lots of other targeted drugs. So it is no longer going to be just chemo, chemo, chemo. There will be new therapies coming through very soon. So to finish, primary breast cancer, we know an awful lot about the biology, but metastatic breast cancer evolves. So the biology that we measure in terms of the types of proteins and tumors and subgroups in the primary tumor actually changes from the primary to the metastasis. And that makes our job very complicated because we can't go back to the tumor that my surgical colleagues have removed and say this type of cancer, when the cancer comes back years later, this is how we're going to treat it. So increasingly, as Mitch says, we will be doing biopsies. We do biopsies of the different sites of metastases, work out what has changed, and we're going to hear in the next talk a little bit about how we can do that actually even in blood samples now. And that will allow us to be much more precise in the types of drugs that we use if the cancer does come back in these other sites. And as I've shown you, the survival now of patients because of these better treatments targeted to the different types is now really showing big improvements, and therefore patients are going to live longer even if the cancer does come back with, by and large, well-tolerated treatments. So thank you.
Thanks very much, Steve, and that good build up there from Maria Coakley and working in Professor Nick Turner's group. I think this really is one of the most exciting areas, developing a big build up for you in breast cancer. Could make a real difference to the way we manage the disease.
Okay, thank you very much for having me speak here today. I hope you can all hear me okay. So my name is Maria Coakley. I'm one of the doctors who works in the molecular oncology laboratory in the ICR, and I also work in the Royal Marsden Hospital. So because I have a special interest in this area, I have been asked to speak today about what are liquid biopsies and how might they change clinical practice. So when we use the term liquid biopsies, we're using an umbrella term to talk about using body fluids as sources of information about tumours and about cancer cells. So when we talk about body fluids, we can be talking about anything from the fluids surrounding the brain and spinal cord, saliva, pleural effusions, which are the fluids surrounding the lungs, urine, or most commonly, we're talking about using the blood or blood tests to look at information about tumours. And although there's a really big range, as you can see on the slide here, oh, I hope this pointer, yeah, you can see we can get lots of different types of information from cancer cells in body fluids. The one that we are most interested in our group, and one of the best developed source of information, is using ctDNA, or circulating tumour DNA, to examine the cancer cells in the blood. So why are we so interested in liquid biopsies? We believe liquid biopsies have many, many advantages over standard biopsies for patients. So standard biopsies are invasive, they can be painful, they can necessitate accessing very difficult to access organs, they are expensive, patients need to be admitted to hospital for at least a decade and often even overnight, and they provide somewhat limited material from the cancer cells. However, liquid biopsies are much safer. They are less painful. I know blood tests can be painful, but they're much less painful than standard biopsies, less expensive. They can be done at routine clinic visits. And really interestingly, they can capture information from cells all over the body. So this slide here is from a paper published just in the last few weeks in Nature Medicine, really illustrating this point that liquid biopsies can capture genetic information from cancer cells all over the body in a much better way than standard biopsies alone. So this is a patient who, throughout the course of their cancer diagnosis and journey, had multiple biopsies done, and at the same time liquid biopsies were taken. And the biopsies were analysed for changes in the DNA, and although the standard biopsies did show some of the changes in DNA, they didn't capture all of them. Liquid biopsies were able to capture much more of the changes from the cancer cells all over the body. So you can see here in red, these are the changes in the DNA that were essentially missed by standard biopsies alone. So we're really hopeful that liquid biopsies could be utilised all throughout a patient journey. There's a lot of interest in developing liquid biopsies for screening the general population and for early diagnosis of cancers. Then when patients are diagnosed with an early cancer, we're very interested in using liquid biopsies to aid molecularly profiling that patient's particular cancer and aiding with prognosis and treatment planning in that early stage of disease. Liquid biopsies then can be also utilized to detect things like residual disease after surgery or radiotherapy and to monitor for a relapse. And I'm going to talk a little bit more about that in the coming slides. Liquid biopsies can also be used in patients with more advanced disease in a serial manner. So rather than having lots of repeat painful standard biopsies, liquid biopsies can be utilized to monitor patients throughout the course of their treatment. And what is really interesting is this can provide information just not on, yes, a patient is relapsing, yes or no, or they're becoming resistant to treatment, yes or no, which is what you really get from a scan, but it can tell you how these patients are relapsing and what the particular genetic changes are making up that relapse. And we call that clonal evolution of the cancers. And we're very hopeful, and I'll talk about this in the coming slides as well, that this can be aided, this information can be used to aid in forming treatment choices for patients. So we're really hopeful that liquid biopsies can get into the clinic and into routine clinical practice. So to do this, we need good clinical studies which show that we can detect signs of cancer in the blood and other body fluids. Then very good clinical trials need to be done showing that liquid biopsies can select patients for treatment and improve upon current management. And with all of this, we want to move liquid biopsies into the clinic and into routine clinical practice. So I'm going to show you over the coming slides just an example of a clinical study and some clinical trials that are ongoing to help to do this. So this is a study called ChemoNear, and this was carried out by the group that I currently work with. And this showed that liquid biopsies could detect early relapse for breast cancer patients. So here, I'll talk you through what I've got. So patients were recruited into the study early on in their diagnosis when they had a blood test taken. They then had neoadjuvant chemotherapy, which refers to chemotherapy before surgery, their surgery, and then a post-surgery blood test or a liquid biopsy at that point in time. And then they had serial blood tests every 6 months during the follow-up period. And this showed that on average, liquid biopsies detected recurrence of their cancer on average 10.7 months prior to a clinical relapse. So we can look at this another way. So this is the months from study entry. Here is time 0 when patients entered into the study. And I want to draw your attention to these patients on treatment in the red. So these are patients who had ctDNA detected in their blood system. So where the bar is black is before they had ctDNA detected. The part which is red is when ctDNA was detected, and where the bar ends is when the patient clinically relapsed. So what I'm saying is that the average time point for this is 10.7 months. But what I think is really, really striking is that for some patients, this time period was really long, sometimes even up to years. So this really begs the question of, could you do something at this particular point in time when ctDNA is detected to change a patient's course of disease at that point? Could you maybe delay their cancer coming back or maybe even prevent it from coming back? So this has led to the development of a clinical trial called CTRACK-TN, and this has been coordinated by the Royal Marsden and the ICR and is currently running in over 10 centres throughout the country. So patients with early stage triple-negative breast cancer have their standard treatment of surgery, radiotherapy, and chemotherapy, and they then enter a program of liquid biopsies screening for early relapse. For patients where ctDNA is detected, there is then an option of enrolling onto a clinical trial involving immunotherapy. So jumping to more advanced disease then, Plasma Match is a very large clinical trial also coordinated by the Royal Marsden and the ICR. And this trial is using ctDNA to select patients for treatment. So what is really special about this trial design is that when you're looking to use targeted agents in the metastatic setting, you need to screen lots of patients who have the particular mutation that your drug you think will work for. Doing this with standard biopsies is just essentially impossible. And doing thousands of biopsies would be really unethical for patients. However, with simple routine blood tests, a large population can be screened, and from that you can pick out patients with mutation A for cohort B A, patients with mutation B for cohort B, mutation C for cohort C, and so on. At present, not every patient on the study will have a trial available to them, but the trial is dynamic in its design and can be expanded over time to add on future cohorts as more experimental treatments become available on trial. So Plasma Match is still ongoing, and we don't have all of the full results yet, but we do have some preliminary results, and it does look like this is a very promising way of guiding treatment. So all of you will become expert radiologists by the end of this evening. But here we've got some CT scans. So this one is from, these two are from the same patient with what we call an AKT1 mutation. And this patient received an experimental combination of drugs of AZD5363 and fulvestrant. And at baseline, this patient had a lesion in their lung. And you can see that at 13 months of treatment, this lesion is much, much smaller and well controlled. So this patient has an ongoing response at 13 months on treatment. Similarly, this patient with a HER2 mutation at baseline had quite large, bulky disease in the lymph nodes and breast. And at 28 months following of ongoing treatment with neratinib and fulvestrant, this patient's disease was essentially undetectable. That's over 2 years of treatment with an ongoing response. So even though we don't have all the data yet available, these results are really, really promising. Oops. I have one last slide. So in summary, liquid biopsies have many advantages over standard biopsies. They hold great potential to aid with diagnosis, prognosis, and monitoring of patients all throughout a patient journey. And there are currently multiple studies and clinical trials ongoing, aiming to bring liquid biopsies into routine clinical care. And a really big thank you to all of you, to all the patients and families who participate in clinical research and clinical trials. And thank you for listening.
Thanks, Maria. I think throughout the presentation so far, you've kept hearing about trial. And it's because we really need data to take these advances forward, the evidence to present to NICE. Many of these things are expensive. One of the other advantages, I think, potentially of the circulating tumor DNA, liquid biopsy, it can give you a surrogate endpoint. The sort of slides that Steve and Alistair were showing require that patients recur. We need a number of patients to recur or progress before we know whether there's a difference between the two groups. Circulating tumor DNA has a promise also of being a reliable endpoint. If we can show that our new treatments are suppressing that and keeping that suppressed, we may be able to understand these drugs are actually effective much earlier. That, again, needs a trial, but if it does, it can bring forward the advances that much more quickly. I'm now going to, last presentation, welcome Carol back to the stage. Going to give us her own perspective on, whoa, are you okay? Okay, that was a different perspective. Carol.
Thanks, Mitch. So I've got the same juggling act thing going on, so do bear with me. So, you know those times in your life when everything is just kind of ticking on quite nicely, and then suddenly the rug is pulled from underneath your feet and you're down and you've got to work out how you're going to get back up again. Well, that was what I refer to as 2013 in my life. At the end of the spring of 2013, was diagnosed with primary breast cancer. And by the end of the summer, I had the additional issue of my personal life being in complete shreds. So in 6 short months, life as I knew it had completely crashed and burned. So when Mark asked me if I would like to come and speak this evening about the importance of options and hope, that was the point in my life that I flashed back to. Because even though it was a time when I was really scared and clearly quite vulnerable, it didn't really matter how much of a kind of disaster was going on with everything else in my life after my diagnosis. I had this overwhelming, unwavering, positive expectation about my treatment. And that was quite simply because I knew that there had been so much research, there had been so many studies, there were so many trials that had given so much information that my team were able to be very confident in their recommendations of what was going to be best for me. So to know that they had that knowledge and to know what to do with that knowledge to treat me, that was just something really special. It was something that really gave me confidence, and with that confidence gave me optimism. So that really helped me to feel really not good, but really quite positive about what lay ahead. So, like many patients, I spent a lot of time in the hospital, and sometimes just to distract myself in a strange way, I would try and keep my professional brain ticking. And I would look around me for things that I could relate to, things that I could learn from, just try and make some use of my time, rather than just being in a patient setting, but to think about what can I learn? What am I going to be able to take back into the real world with me once my treatment has finished? And I have to say that things didn't quite end up the way that I'd expected, but there was still a positive slant. So the story behind that is that I had decided to have immediate reconstruction when I had my mastectomy. And as was normal practice, my clinical nurse specialist very carefully and diligently selected some photographs to show me of what I might be able to expect post-surgery. Now, that's an approach that clearly works for a number of people, but for this self-confessed control freak, that really wasn't cutting it for me. I didn't really feel terribly comfortable about it. So there isn't time this evening for me to share with you this really odd story about how I managed to find out about this piece of 3D camera equipment that had the potential to change that experience that other people would have for others in the future. But through another set of really strange circumstances, I found myself in a position where I was able to lend my voice and my views to a funding application for a study that would use that precise piece of equipment. And I'm delighted to report that that funding application was successful. I'm not so delighted to report that I still can't feel the ends of my fingers, so I can't turn the page over. Bear with me just one sec. Oh, it's okay. Thanks anyway. But thank you. So some really quite amazing things came out of that funding. Firstly, it provided an opportunity to engage a phenomenally talented MD student. She achieved great things while she was here. In fact, she just left today. And one of those things was something called the SIM study. Now, 120 women participated in that piece of research, and the intention of it was to determine the most effective method of measuring satisfaction of outcomes following breast reconstruction. And around a third of those participants had an opportunity to utilize that 3D photography to predict their outcomes. Now, the final results of that particular study are not quite yet available, but the preliminary data is really super encouraging. And actually, the template for that particular study has already gained some traction, and it's being rolled out to 10 other trusts around the country. So I personally am extremely excited by the fact that means that there are going to be even more women who are going to have their opportunity to lend their voice and their views to the study. So I was quite delighted that sharing my views was actually something quite useful. And that really spurred me on to look at other ways that I could use my skills and energy, I guess, to get involved in other things. So since then, I have had the honour of being involved in a number of studies and development opportunities. And when I've thought about how I can best use my skills, the way that I've done that is to be able to help write some protocols. I've put together some web content. One of the things that really resonated with me was some of the information that some of the research doctors use when they're talking to patients about studies. I thought that there was maybe a slightly sexier way of doing it, so I looked at designing an infographic to support the SIM study recruitment, and I'm happy to let you know that actually worked out quite nicely. I also had the opportunity to facilitate all of the lovely ladies that participated in the SIM study, and I get involved in some steering groups, and also have had the opportunity to engage with some coaching. You won't believe it from what you're seeing this evening, but I did actually coach some presentation skills a little while ago. So the reason that I'm sharing all of this information with you is because I truly believe that if you are passionate enough about wanting to help with research in some way, shape or form, you can. You just have to find the opportunity. Now, my interest in the world of breast cancer research specifically stepped up a gear in 2017. Unfortunately for me, it was almost like 4 years to the week after my primary diagnosis that I received my secondary diagnosis. Slow turning over the page again. So for me now, it's not just about knowing about the importance of research. Now I really feel the importance of research, because without beating around the bush, literally it's the research that's happened before that's keeping me here. And I'd like to think that it's the research that's in progress right now that might add to that. So I remember after getting my secondary diagnosis, one of the very first things I asked was, well, so what are my options? And actually, it was knowing that I had options that really helped me to navigate through the devastation of the diagnosis. It was knowing that there was stuff that could still be done as a result of all of that research and all of those studies. That was it. There was an opportunity out there for me, just as Alistair and Steve have presented this evening. So I know from my own work that, and my own understanding of brain function, that when you have hope, that has a really positive impact on your brain chemistry. Now, by hope, I mean the authentic kind, the stuff that has got some roots and some grounding in facts. I won't pretend that I don't still look for 2 magpies, and I do actually have a variety of lucky charms. However, it is all about the real hope. It's a luxury. It's calming and it promotes positivity, and it's a much better place to exist in than a head full of fear and negativity. So, like many of you, I'm sure, I used to and still do get a number of messages from people sharing news about breast cancer treatments. And initially, to be completely honest, I used to find it really irritating. I used to think, okay, so what exactly is it that you think the Daily Mail know that my team at the Marsden haven't come across already? And then I would be irritated by the fact that maybe people thought that breast cancer was just one thing and that we would all receive just the same treatment. But then actually I stopped being quite so grumpy and melodramatic about it. And what I then realised was that all of those well-meaning messages highlighted something truly incredible. What it means is that research is creating a brilliant stream of potential, whether that be new drugs, whether that be new combinations, whether it's about tests, whether it's about interventions. All of this new stuff, it's phenomenal because it's giving hope for people for the future. Now, some of that is not necessarily relevant to me or to my disease, But with so many variations of this disease, I'm sure everybody in the room would agree that it is quite incredible to think that so many patients and so many people who have patients as loved ones or people that they care about are going to have hope, and potentially they're going to get some peace of mind. So having confidence in the potential curative options with early diagnosis is clearly absolutely amazing. And being hopeful about the range of treatments that can support you through living with the disease is brilliant. I know that. Now, clearly I am not a doctor nor a scientist, but that doesn't mean that I want or don't want to leave an equally indelible footprint in this life. And that's why now I spend so much of my time looking for opportunities to be involved in studies and by really having that purpose of being able to contribute positively for the future. So right now, of course, as you heard earlier when I was presenting with Rebecca and Catherine, right now my hope is that just something that I might do may end up helping 23% less women know what it's like to be a breast cancer patient. So what I really want to have achieved during my time here with you this evening is I want to have demonstrated that it is absolutely possible to be part of research and options and hope for the future. There is so much going on, as you've seen just a snapshot of it this evening. But people's time and expertise for all of the skills and services that don't naturally exist within a hospital or a research facility setting can be really quite expensive. And what I want to share with you is that getting involved has a knock-on effect. So a number of people that I know are actually, they're pretty cool with the fact that I donate my time, and they respect that. And so in turn, they offer me their time. I've been able to go to or reach out to a number of people to help me with some research that's helped informed some real key presentations over the last year. And some of my professional colleagues have really helped to reinforce some of the stuff, some of the professional contributions that I've made to some of the study content. I'm not going to pretend that the meeting of a commercial mindset with the world of the health service and the red tape and the bureaucracy that exists within it is easy. Sometimes it really isn't. The rules of engagement within the health service are very different to that I'm used to in my commercial world. But having said that, it's my choice to be involved. And so it's my choice to do as much as I can for as long as I can. And what I'm hoping is that by me sharing what I've been able to do is going to have triggered something in somebody this evening, at least somebody this evening, for you to want to get involved too. And there are lots of opportunities for patients and members of the public to engage in supporting research. And I've got no doubt about the fact that apart from one guy down in the corner over there, there will be a number of people here this evening that will be delighted to point you in the right direction if you express that level of interest. So I want to bring you back full circle to where we started, which was looking at whether research drives hope and whether research drives options and whether options fuel hope. And this is my perspective, that hope is the little voice that whispers maybe when it seems that the world is shouting no. Thanks for listening.